Okay, may I start uncrossed to crossing the heart block? So my case, I did this on August this year. He is 60-year-old man, atherogenic risk hypercholesterolemia only, and suspected target lesion failure with positive treadmill stress test. He underwent previous PCI in 2018 on proximal RCA with Onyx and proximal RPL also with Onyx, and uncrossed balloon admit LCX CTO. In 2019, we did OCT-guided rotor stent CTO for proximal circumflex after we crossed the CTO lesion with guide wire, and we placed another Onyx. So this angiogram was done just recently, 2 months ago. This showed the previous Onyx stent on the circumflex, where it was CTO. And you can see that this is the angiogram of the circumflex. LAD is apparently normal. And this was the fluoroscopic image of the proximal and mid RCA with Onyx. And also, one sent the RPL, also Onyx. And he came because of positive treadmill test. And you can see the angiogram show the TME1 flow. It was blocked at the distal RCA before crux with faint visualization to RPD and RPL. So this, another view showed a very tight lesion here we call functional CTO with flow to the LAD and no flow to the RPL stent. So this is we call functional CTO and the landing zone. So initial we wide with through the FC and cross the functional CTO proximal cap. You can see that through the hit at this one, there is a calcium around here. So what should we do next? So we use 5 cross and we exchange that filter with Gaia first. We try to traversing the functional CTO distal RCA. We succeed in crossing into the RPL. After we crossing this CTO, I said I should use the best CTO balloon that I have on my shelf. So I choose balloon. So balloon that I chose was Alveo HP 0.75. And you may know that the crossing profile is 0.156 inch, the smallest in the world dimension. And this balloon came with diameter from 0.75 to 2 millimeter, but they are range from 75, 125, 15, with length of 5, 8, 10, 12, 15, 20, and 30 millimeter. And balloon pleats came with bifold for 0.75 and 1 millimeter. Nominal pressure is 10, and red burst pressure is less than 29. So this is a cartoon of this the Alveo balloon. When it inflates up to 28 atmosphere, it can crack the calcium dimension like that. So we try to use Alveo first, but unfortunately, uncrossed Alveo. It may cross a little bit. So what shall we do next? I change this to tonus. Normally for uncrossed CTO lesion, I try to exchange to rotor wire and do rotablator, but in this case, the landing zone for rotablator may be too short. So I select 2.1 French tonus. And you can see from this image, there is thickened density tonus compared to the balloon. So this is tonus 2.15, 2.1 French, sorry. And this is a tonus that we tried to use hand drill. It's similar like rotablator, but it is poor man hand drill. But again, we cannot totally cross the tonus. The tonus is sitting here, just before the RPL stent. We try very hard. When we try to push tonus, it slips back the guiding catheter. So we parking tonus in the CTO lesion. The Gaia first was pulled back to make sure that the Y, when we try to push anything in advance, the distal Y may not perforate the distal vessel. and we rewire with the filter FC via tonus. That quite is a little bit friction, a little bit resistant. So this is filter FC via the tonus. We wire to this solution, and we hope that after we pass partially tonus across that functional CTO, we can do something more better with the Alveo. So in this case, we push the Alveo. You can see that during we pushing the Alveo down, the guide flip back. That is normally when we face the very hard block. But we finally successfully crossed. This is the Alveo balloon, 0.75 by 10. We cross with Alveo, and this is the previous stent edge. This is the first copy of the proximal stent edge. After we cross with 0.75, we exchange to 1.5 by 15 rewrite balloon. And after that, this is angiogram. And then we can see more on the distal vessel runoff. It's better than previous. And we can further escalate balloon size to 0.5 semi-compliant balloon splinter legend. And after that, you can see the lesion with bifurcation. So this is a 111 Medina bifurcation. So what we are going to do next, we have to put a stent into this distal RCA to the RPL to overlap the previous stent, and we try to protect this RPD branch. So we put the balloon, we put the stent in, we wire the side branch RPD, fill the FC, and we successfully wire the side branch with this fill the FC. So this is balloon 2.5. This is the still image. We inflate the side branch balloon with 1.5 by 15 rewrite. And now it is time for stent. So this is a stent crossing from the proximal to the previous onyx to the distal RCA runoff. And we paste the stent just overlap the previous stent. After we stent was placed, we try to recross the stent strut to RPD with a fill the FC. You can see that it can pass through the stent strut, not so difficult. And this is the final angiogram. We do sequential balloon for this RPL and RPD. And this is a final angiogram. So in this case, in my summary, this is a case with worsening angina. The indication is ischemia-driven target vessel failure at distal RCA. We call ID re-TVR. And it had calcified functional CTO cap. Unfortunately, we demonstrate uncrossed 0.75 by 15 Alveo HP, but it is partially crossed a little bit, 1-2 millimeter. And then we exchange this Alveo to tonus 2.1. And again, tonus was not crossed. And we come back to the Alveo, and we successfully crossed with the 0.75 by 15. And we successfully do the provisional main branch stenting with KBI. In this case, I use the MAD strategy. M is for main branch, A is main across side, D is distal first, and psi is side branch first. This is the acronym from the global leader study. So we use the main across side branch, and then we do the kissing balloon inflation for both branch. So in your case, in your lab, when you face a tough CTO, in my case, I call functional CTO. Please choose your workhorse CTO balloon. In my point of view, the smallest balloon catheter CTO, special CTO balloon catheter now is Alveo HP 0.75, and you can choose from length of 5, 8, 10, 12, 15, and 20. I wish that you can get a more success when you met with the very hard block, the difficult CTO, calcified CTO lesion. Thank you very much for your kind to listen to my presentation. Thank you very much.
Thank you, Dr. Damras. Thank you for contributing a very good start. Now we will come to the discussion part. So is there any questions for discussions? Maybe our other experts will have some comments, right?
Yeah, I just want to say thank you. That's a great demonstration of having the right tool makes life very easy, because it's quite nowadays we are faced. I think I'll touch on this in my talk in a minute. We are faced with a really aging population, complex disease, lots of calcium, uncrossable lesions. So having the right tool makes life very easy. And there's a lot of publication about the algorithm, how to treat uncrossable and dilatable lesion. And one of the first approaches is having a low profile effective balloon. I think what we have seen there has been many on the market, obviously, but I think what we're finding right now is the Alveo has done a very good job so far. And I said, I'll show that in some of my cases too.
So maybe my comment, I think it was a very great case. One technical remark, I would not go for tonus, but try to engage partially the alveoli and then inflate it. And
I can't hear you.
Maybe crash a little the proximal cap and then go on. Or maybe it was a place for granuloplasty as well, with alveoli balloon to crash the proximal cap. However, it was a really great case, and tonus was a very elegant way to do as well.
Congratulations, Dr. Damras. It's a very great case. And I may ask you one question. Do you have any other option if we work in the lab that the tonus is not available? Is there any other option to cross this lesion?
Actually, my lab, we have plenty of machine and device. 10 years ago, I prefer to use laser with let's say 0.9 millimeter. That is my first choice. But now the laser machine is out of date. And the Spectranetics went to Philips medical system, and then they increased the laser catheter price very high. So we are not able to purchase the laser catheter. The second way, if you don't have tonus, you can advance a guide liner a little bit more distal and push through the guide liner. But in this case, I did not use guide liner because there are on extent 2 or 3 pieces of on extent on the proximal RCA. And I'm afraid that when I advance guide liner, I may have to do the balloon tracking. So pass guide liner down the previous stent that I implanted 4 years ago. So that I try to avoid, but if there is no tonus, I'll use that. And the last one that I mentioned, when I cannot cross with the best balloon that I have on my shelf. Actually, we have 3 brands of balloon. Of course, Alveo 0.75. Then we have Ikasushi 1.0. And then we have the Sapphire 1.0 balloon. So we have some choice. But when I opened this Alveo 0.75, it did not cross. I did not try another balloon. So the last technique is to exchange the Gaia first, or exchange the filter with rotawire. But I mentioned already that when you pass rotawire, you must have a space at least 8 centimeter long enough for rotarun. And in this case, when I look at the RPL or RPD, the space is very limited, and we try not to run rotablator into the transition between the soft tube of wire and the chuck of the rotor wire. You can break the wire and lose the wire in the distal vessel. So I answer your question that tonus, use a guide extension catheter tonus, guide liner or guide plus or whatever. and try to push and do like the Dr. Gorgesky mentioned that we try to do balloon and do the cranuloplasty. But you have to spend another 1, 2, 3 balloon, try to advance slowly and do the balloon and burst it. Cranuloplasty to break the cap, and then you can pass the balloon. But I did not do it that way. I exchanged to Tonus first. But Tonus, that's a cross. But it worked in some limit. It works some, and then Alveo do the rest of the crossing. Thank you for your question.
Yeah, the similar kind to catheter to Tonus is the term by gold, which has a good because it has that kind of curvature on it to a kind of a good hook to the lesion. But for me, again, laser is probably the one that I would reach to if there's uncrossable lesion.
Yeah,
I was still privileged to have laser around and we use it frequently. So it's quite, in fact, actually, one of the cases I'll present, there was laser used. So
in the last 10 years, we at Sirat Hospital in Thailand, we are the #1 laser user in Asia Pacific, including, compared to Australia, India. I was proctor for the laser spectrometric to India and to many countries to show the laser work. We tested 0.9. It's quite nice, quite nice.